Okay. So let me make just a very small clarification about the title, because it is the CT in a stable chest pain. But of course, when we have to speak about the risk stratification, we should also consider patients with pouchy symptomatic patients or asymptomatic patients as well. So let me start with, briefly with the outlines of this talk, starting from the definition of the characteristics of coronary artery disease and moving to the definition of the prevention and risk stratification. So showing you the limitation of the more used clinical risk score for the assessment of risk of cardiovascular risk in subjects, and defining the role of calcium score in coronary CT angiography, and the prognostic role of cardiac CT as well. And then I would like to underline also the role of detection of subclinical atherosclerosis in a symptomatic subject, and the paradigm shift from stenosis to atherosclerosis detection, and the population from versus single patient based risk stratification and screening. So, starting from the definition of a coronary artery disease and cardiovascular disease, we know that cardiovascular disease is the leading cause of death and health expenditure in the European and Western countries, and this is the most updated statistics from American Heart Association in 2016, and it showed that cardiovascular disease accounts for more death and disability than all cancer combined. And among the different components of the cardiovascular disease, the coronary artery disease absolutely still rules the roost. So we know that cardiovascular disease, and particularly coronary artery disease, is a chronic disease starting from the childhood, and it develops silently over years, emerging as the greatest killer worldwide, with a very wide clinical spectrum from stable angina to sudden cardiac death. We know that coronary artery disease has a long preclinical phase, so we should have many opportunities to modify the course of the disease and consider reliable the diagnostic tools for determining which subjects with atherosclerosis will develop symptomatic disease in the next future. So, understanding which patients with coronary artery disease will suffer of coronary or cardiac events or remain asymptomatic during their life, is really a topic of intense investigation to prevent the coronary artery disease. So, we know that the screening for early stage asymptomatic cancer to prevent late-stage malignancy has been widely accepted worldwide, if you think about the breast, the cervical, the colorectal or lung cancer. We have already seen that cardiovascular disease accounts more death and disability than cancer combined, but to date, there are no screening guidelines for coronary artery disease. That means to assess coronary artery disease, subclinical atherosclerosis in a symptomatic subject, while the assessment of coronary artery stenosis only follows the suspected symptomatic coronary artery disease and atherosclerosis. So why not screen for subclinical atherosclerosis? This is an editorial published on Lancet in 2011, and the editorial underlined that the only effective approach to reduce the loss of life, the health burden, is to prevent the disease itself. In other words, the primary prevention. But the public health initiatives are important, but so also is important the personalized prevention for those people characterized for high risk for cardiovascular disease. So, move to the first questions about the risk stratification. Which is the right one of the following sentences that describe what is risk stratification? Risk stratification is useful to identify low-risk asymptomatic subjects without established disease who are candidates for aggressive medical therapy for primary prevention. Or is useful to identify the moderate-risk asymptomatic subjects without established disease and candidates for aggressive medical therapies for the primary prevention, or to identify those at higher risk, always asymptomatic subjects without disease and candidates for aggressive therapies for primary prevention. Letter D is that the risk stratification includes all activities from lab and cath lab, diagnostic tests, and so well, to determine a risk of a people for suffering a particular condition and need for treatment. Finally, risk stratification test is able always to divide subject in two well-distinct categories, healthy and diseased. So, please vote. May we move to the answers? Okay. Most of the answers are letter D. So it's not correct, and I'll show you why. The right answer is letter C. It's useful to identify the high-risk asymptomatic subject without disease and candidate for aggressive therapy for a primary prevention. So this is a really hot topic. The screening of coronary disease is a really hot topic in the cardiology arena, but we know that the assessment of asymptomatic individuals without known CAD but with atherosclerosis could be really useful because it classifies the risk of the patients, it allows to perform diagnosis of disease, and useful to inform medical management. So, what about the screening technique for high-risk asymptomatic subject? When we use the terms high-risk asymptomatic subject, we should define what does it mean, high-risk. So it's which people, for whom and by which method we can consider these people high-risk subjects, and are they really those at higher or highest risk for disease? So the risk stratification includes all constellation of activities from lab and clinical testing to determine the risk of a single subject for suffering a particular condition and need, but not for the treatment, but for preventive intervention. So we know that we have different steps of prevention, primary, secondary, tertiary prevention, but usually the risk stratification for coronary artery disease include all strategies to identify the high-risk asymptomatic subjects without disease, established disease, and candidate for aggressive medical therapy for primary prevention, not for the treatment. So, the ideal diagnostic test useful for a risk stratification could be divide subject to well-distinct categories, the healthy and diseased. But we know that this is not the reality because there is a certain sort of overlapping between the results with the presence of false negative and false positive results for each test. So, moving to the second question. Coronary angiography. Is it the gold standard for coronary artery disease? It's still the gold standard, but is it an accurate predictor of acute myocardial infarction? Letter A, yes, because the majority of acute myocardial infarction are due to significant stenosis. No, because the majority of acute myocardial infarction are due to non-significant stenosis. Yes, because the minority of myocardial infarction are due to non-significant stenosis. Yes, because the severity of stenosis may be adequate to predict the time and location of subsequent coronary occlusion in coronary angiography, of course. Letter E, yes, because it's a simple luminographic technique. Please, vote. Maybe move to the results. Okay, letter B and letter D. So, move to the presentation. Okay, the right answer, of course, is the letter B. No, because the majority of acute myocardial infarction are due to non-significant coronary stenosis in coronary angiography. I'll show you why. So this is a quite well-known meta-analysis published by Falk and Fuster on Circulation 1995, and it demonstrates that most of the acute myocardial infarction arise from stenosis that are not significant on coronary angiography, below the threshold of 70% lumen reduction. So probably the gold standard should be the intravascular ultrasound instead of the coronary angiography. So some cases from the literature, the assessment of angiographic severity of stenosis may be inadequate to predict the time and location of subsequent events. This is a patient with occlusion of LAD and with some irregularities on obtuse marginal branch, but without significant stenosis. So the patient 2 months later had a lateral myocardial infarction due to the occlusion of the obtuse marginal branch. This is another chap with some very small, thin irregularities on the wall of the right coronary artery in the middle portion of the vessels, without any significant obstruction, of course. The same patient had, 30 days later, an acute myocardial infarction due to acute right coronary artery occlusion. So coronary angiography is not able to predict the time and location of the events. Move to the coronary angiography. This is a 2-single frame from left system. So the right anterior oblique projection and the spider view of the left system. So this is a trifurcation of the left main artery. And how do you consider this projection? Okay, the vessels are good. There is nothing of significant, of course. Probably just a very, very, very thin aspect of the proximal LAD. So more or less, we can consider this almost normal. By CT, we are able to detect the characteristic of the wall of the vessels, so we can assess this segmental, non-calcified, very thin hypodensity along the proximal portion of the left anterior descending artery, and by cross-sectional imaging, we can define the disposition and the characteristics and the effect on the residual lumen of the vessels, assessing this case as an eccentric non-calcified plaque with less than 50% stenosis in proximal LAD. So we can assess by CT, by non-invasive imaging, the wall of the vessels that is not able by coronary angiography. Move to the question 3. What is the coronary plaque burden? It is represents the calcium score of a single coronary plaque. It's an index for a stenosis degree. It represents the number of stenosis along a single coronary vessel. It's the summary of all characteristics of the plaque present in the patients, or it's the total number of coronary stenosis in a single patient. Please vote. We can move to the results, please. Well. Okay, letter D, the summary of our plaques characteristics. It's right, it's the right answer, of course. So when we can assess non-invasively the coronary artery, we have already seen. So when we assess the coronary arteries, we can assess the distribution of the disease, defining in the proximal, mid, or distal distribution of disease along the course of the vessels. We can define the position of the plaque, is an eccentric or concentric. We can define the length, is a focal or is a segmental. We can define the grading. Usually we use the threshold of 50% to define the significant or non-significant value of the stenosis. We can characterize the plaque as non-calcified, that includes both lipid and fibrosis generally, the mixed plaque and the calcified plaque. Of course, we can assess their remodeling. It could be possible positive or negative remodeling. Typically, the negative is in the chronic disease. The positive is the so-called unstable coronary plaque. And then all these parameters taken together represent the plaque burden of the disease in the subject. So, move to question number 4. Just a practical example. These are a curved multiplanar reconstruction, the stretched one, and the oblique reconstruction of the left anterior descending artery in a single patient. So, the question is, okay, there is something in the proximal portion. What do you see and how do you describe? In particular, the questions are, is this an concentric and segmental mixed plaque with severe, more than 50% stenosis in the proximal LAD? Or is this an concentric local mixed plaque with severe, more than 70% in the same proximal portion of the vessels? Again, it's an eccentric and segmental mixed plaque with severe more than 70% stenosis, or is an concentric, focal, non-calcified plaque with severe more than 70 stenosis in the proximal LAD, and finally, is an eccentric, segmental, non-calcified plaque with severe stenosis more than 70% in the proximal LAD. Please vote. May we see the results, please? Good. The most of the answers are letter C. Okay. And the right answer is letter C. This is an eccentric segmental mixed plaque with severe stenosis in the proximal LAD. So now try to analyze it, of course. This is a coronary angiography correlation with a movie and a freezed frame. You can assess by angiography the disposition of this disease. It's typically eccentric, of course. There is something calcified in the proximal portion. There is something here, high-density components in the proximal in this portion. But of course, we have to assess on the cross-sectional imaging, and particularly the red one, the red boxes, will show the disposition of the plaque, the residual lumen, the calcified component in the eccentric on the lateral wall of the vessels. And so we can really define these as an eccentric segmental mixed plaque with severe, because absolutely it's more than 70% stenosis proximal LAD. Okay, so we know that coronary artery disease is really an heterogeneous disease with hundreds of risk factors documented in the literature, and making the phenotypic screening a reasonable approach for the screening of this disease. We know that we could assess the asymptomatic coronary artery disease as a risk factor for coronary heart disease, and asymptomatic disease means that there is no myocardial dysfunction, of course. So introducing the concept of a plaque burden as a risk factor may be pushing the envelope of primary prevention into the territory of the secondary prevention. So this is the slogan by the European Society of Cardiology, to reduce the burden of cardiovascular disease in Europe. So that not be just a slogan, we should continue to search for better ways to identify those patients that are really at higher risk for coronary artery disease, so that we can be able to make an aggressive treatment to target this population that are resulted to be at higher risk, to spare those that are not at risk, but on the other side they are really at extremely low risk, and finally we should spare costs or side effects of protracted therapy during the life of the patients. So, talking about coronary artery disease, it seems too logical to ask these questions. Instead of simple measuring the risk factors that are quite modest, that show a modest relationship to the presence and extent of disease, can we actually detect the disease before it determines the catastrophic events? The detection of subclinical atherosclerosis could provide an integrated view of cumulative exposure to known as well unknown risk factor and risk modifiers. And so it probably is allowed to offer a better risk for stratifications. So this is the typical flow chart. In a patient with suspected coronary artery disease, we have diagnostic tests at the first of higher levels, and of course, usually they are followed by the coronary angiography, that is still considered the gold standard. And in well-selected patient, we have the CCTA, coronary angiography. But from the data and literature, we are able to move up the role of CCTA before, of course, of coronary angiography. So these are two paper published on important magazine, New England Medical Journal in 2010 and JAMA in 2013, and both papers well analyzed the rate of obstructive coronary artery disease in a patient with a suspected coronary artery disease undergone to elective coronary angiography. And from both papers, it's quite dramatic that most of the patient does not have significant disease. More than 50% of this patient doesn't show significant coronary angiography disease. So we can use alternative non-invasive imaging, and particularly there are some papers that has analyzed the cost effectiveness of coronary CT angiography and its impact on coronary angiography utilization during the workflow in the diagnostic routine. So this paper will show that there is a significant reduction in frequency of normal coronary angiography in low-risk patients undergone to coronary angiography in elective mode. And as well, we are able to reduce the number of coronary angiography examination, as shown by this German group. And in particular, we are also able to reduce the nuclear medicine tests, like myocardial perfusion imaging and nuclear medicine tests, as well as the treadmill exercise test. But when we have a new diagnostic technique, of course, the spread of this new technique starts from the innovation phase to become well-established test, and it goes by several steps. And usually the last step is represented by the definition of the prognostic value of this new test. And more or less 10 years ago, it was published the first paper about the prognostic role of CT angiography in a patient with known or suspected coronary artery disease. And the Kaplan-Meier curves will show the stratification of the risk for coronary events in the follow-up of this patient among patients with normal coronary arteries, among patients with atherosclerosis but not with obstructive disease, and what's the situation with patients with atherosclerosis and obstructive disease. The same results for the left main system and left main artery and left anterior descending artery. But so CCT angiography is an independent predictor for coronary artery disease, showing an independent prognostic value. But it is able also to provide an incremental prognostic value above the baseline clinical variables, as well as on the myocardial perfusion imaging, in particular when the perfusion imaging is normal. So move now to the clinical traditional cardiovascular risk factors. Question number 5. The clinical risk score, typically the Framingham risk score, the Euro score, we will see some examples. Which one of these following sentences is correct? The clinical risk score for risk stratification are applied in symptomatic population. They are single patient based. Are they based on the imaging findings, or are they population based? Finally, they are the standard just because validated through randomized controlled trials. Move to the result, please. Good. Most of the answers are letter D. They are population-based, and the right answer, of course, is letter D. They are population-based. They are not single patient-based, of course, and we will show why. So this is an example. This is the so-called Euro score. It is elaborated by the European Society of Cardiology. It assesses the total cardiovascular risk in subject, men and women, assessing the risk of dying from cardiovascular disease over the next 10 years, assessing the gender, smoking habits, total cholesterol, and systolic blood pressure. This is another example of to assess the risk in a patient with systemic hypertension, assessing several parameters, and to define the best clinical approach to limit the risk of coronary artery disease and to limit or avoid the complication of this disease, of course. So the risk stratification, the Framingham, this is the well-known clinical risk score. It used simple and easily measurable variables for risk factors. It able to predict a priori the risk for a population to show disease in the next future, typically in 10 years interval, dividing subject into arbitrarily constructed categories, the low, intermediate, high risk cohorts. And everybody can assess their own risk on a website. This is, I assessed yesterday my results, and I'm quite lucky because I'm still in the very low risk score. So the National Cholesterol Education Program, Edu Treatment, the so-called NCIP guidelines, couple the intensity of the treatment, of the therapy, to the magnitude of the assessed risk by the clinical risk scores. But although these guidelines have never been validated through the randomized controlled trials, they are the standard template for prevention because they are they have a very low cost, and they show a reasonable prognostic accuracy. And keep in mind that framing of risk score anyway underscore the variability in the magnitude of atherosclerosis burden between subjects with similar level, profile, or exposure to risk factors that is principally related to other known, both unknown, genetic and environment risk factors. So, move to the question 6, and let me joke with the next two questions. Who has, or better, had higher cardiovascular risk between these two chaps? I think that all of you know who Sir Churchill was. Probably not all knows who Mr. Fix was. Mr. Fix was the guru of the jogging in the 80s in the United States. This is a famous book on the running. So, which of these patients had the highest cardiovascular risk based on the traditional risk factors? Just from the picture. Okay, I think it's quite easy. We can move to the results. Somebody has voted Mr. Jim Fix. Okay, good. The right answer, of course, is Churchill. Why? This is the characteristics of Churchill. He was quite obese, sedentary, smoker. He was a drinker, of course. And Mr. Jim Fix was the opposite, of course. But the same subject. Who died first? Please vote. Okay, move to the result, please. Great. Of course, Jane Fix. Somebody probably has voted Churchill, but the right answer, of course, is Mr. Jane Fix. And Mr. Jane Fix unfortunately died at 52 years old for an acute massive heart attack, triversal disease. And this was on a page of New York Times journal that published this article, The Enigma of the Heart Disease. So, most of the subjects with sudden cardiac death and fatal myocardial infarction do not experience any symptoms prior to the acute events or exertional dyspnea, emphasizing the importance of the early detection and treatment of underlying subclinical atherosclerosis. Most of the study showed that most of the heart events occur typically in people misclassified at low or intermediate risk by the traditional clinical risk score. They are not offering optimal preventive therapy, of course. On the other side, many people are misclassified at higher risk and advised to take therapy during their life, and this is not cost-effective, neither good medical practice, of course. So, although the exposure to casual risk factors is needed, the mere presence of risk factors is not sufficient for developing cardiovascular disease, of course. The level of susceptibility to these factors and the presence or absence of unknown protective factors may play a crucial role in defining the clinical outcome of these subjects. And subclinical atherosclerosis can be really detected by non-invasive imaging, this is an example, and quantified non-invasively to show the cumulative effect of all known and unknown risk and susceptibility factors combined. So we are able to detect now the subclinical disease. But looking for the current guidelines in primary prevention, they call for an initial assessment of and the risk stratification that are based on a typical clinical risk factor analysis, like Framingham or Euroscore we have already seen. And typically, they are followed by the goal-directed therapy when necessary. These are different pathological conditions that are considered like coronary heart equivalent. But today, the existing guidelines do not recognize severe, non-obstructive coronary atherosclerosis as a coronary artery disease equivalent, and so most of the heart attack originated from the non-obstructive plaque. We already seen an example. So we are able to perform 3 different levels of intervention, distinguish maybe performed to prevent and reduce the morbidity or mortality of the disease. And of course, as a radiologist, we can play a role in the early diagnosis of the disease. Coronary CT angiography, or cardiac CT as well, is the only one non-invasive diagnostic technique that is able to discriminate among normal coronary arteries. That means no atherosclerosis, no calcium score, no plaques, and among coronary arteries with atherosclerosis but non-obstructive disease, and the worst situation with coronary artery atherosclerosis disease but with significant stenosis. And all these characteristics, joined to the characteristic of the disease that we already seen at the beginning of the presentation, really open the door for assessing the patient's coronary artery before they manifest the disease. In other words, this is a screening for coronary artery disease. So we have a paradigm shift from stenosis to atherosclerosis detection, and from population, typically from Framingham risk score, to patient-based risk stratification. We can assess the single subject, not the population. Okay? So move to the last questions, number 8. Actually, which is the established role for cardiac CT, both calcium score and CCTA, from the guidelines? The calcium score is suggested in symptomatic patients, while CCTA is suggested in a patient at low risk after a stress test. Letter B, calcium score in asymptomatic subject at intermediate risk for CAD, while CCTA in symptomatic patients at intermediate risk after, an example, an unclear stress test. Again, calcium score in a symptomatic patient at low risk for CAD, and CCTA in acute chest pain with ST elevation and positive biomarkers. Letter D, calcium score in asymptomatic subject patients at high risk for CAD, and CCTA in symptomatic subject after a positive stress test. And finally, for risk stratification in asymptomatic high-risk patients without known CAD. Please, vote. Maybe move to the results, please. Okay, B and D. Move to the right answer is, of course, from the guidelines, actually, letter B. Calcium score in a symptomatic subject classified intermediate risk for CAD, and CCA typically in symptomatic or pauci-symptomatic classified at intermediate risk, not high risk, after an example, an unclear stress test. So, of course, acute chest pain, patient with typical acute retrosternal chest pain, ECG changes typically STEMI, associated with increased cardiac enzyme, of course, has to go directly to the cath lab and not to the radiological nuclear medicine environment. But this is the guidelines, the most recent guidelines for calcium score, of course. It is classified in, it is inserted in class 2A. It's usable or reasonable for cardiovascular risk assessment in asymptomatic adults classified intermediate risk. For CCTA, the situation is quite different because typically is not still recommended in a symptomatic subject for risk stratification, or is still under investigation. But of course, its role is quite clarified in subjects with symptoms, atypical symptoms, and classified intermediate risk, and after an example, unclear or non-diagnostic stress test, typically in class 1, class first. So this is a typical reduction that we have able to got in our department. Now it's a quite dramatic reduction in X-ray dose X-ray dosimetry administered to the single patients. And these characteristics allows to extend the application of the test behind the symptomatic patient to asymptomatic patient, because it's not still really an important problem. And of course, the technical evolution and this dramatic X-ray dose reduction allows to scan patients with less restricted inclusion criteria, that we have already seen for CCTA, with two typical compelling applications in the field of coronary artery disease detection. The first one is as gatekeeper to catheterization to minimize unnecessary invasive procedure, and there's more or less we do that in our clinical routine, or could be useful also to perform a risk stratification for asymptomatic subject, non-patient subject, to target or personalize medical therapy to prevent coronary artery disease. But this is a really hot topic in the cardiological and radiological arena, as demonstrated by numerous papers published in the recent literature. But the starting point on the discussion about the screening of CAD is represented by the publication on a supplement of American Journal of Cardiology in 2016 by Nagari, the father of unstable patient and plaque, of the screening for heart attack prevention education guidelines, the so-called SHAPE guidelines. The SHAPE is a grassroots American grassroots non-profit organization with this mission, and the SHAPE guidelines calls for the application of a non-invasive diagnostic test to assess the subclinical atherosclerosis in a symptomatic subject classified at intermediate risk just for the age of the subject. Except those at very low risk, they suggest the use of imaging to detect the subclinical atherosclerosis, to detect and treat this subclinical atherosclerosis, and to tailor the aggressiveness of the therapy to the real level of the risk for this single patient, single subject. In particular, they calls for application of a test in a apparently healthy, asymptomatic subject defined at risk. So we can perform the imaging test to detect or rule out the disease. Then we can perform a stratification based on the severity of disease and the presence of significant risk factors. And finally, to perform a tailored treatment of a single subject based on the level of the risk of that subject, not for a population. So, actually, by the clinical risk score, we can distinguish three different groups of patients at risk for disease, suggesting the therapy for the higher risk group. But performing an additional imaging screening test, we are able to perform a further stratification in the intermediate group classified by the clinical risk score, so we can increase the number of patients at higher risk for disease to treat them with the right therapy. So the risk stratification to target the aggressive prevention to those that result most at risk and avoid the therapy in those with the least amount of disease really makes sense. But from a societal standpoint, it should be important to establish the ability of CT, both calcium score and CCTA, to predict the outcome of the patients and to demonstrate that the use of this atherosclerosis imaging not lead to an increased cost of the further diagnostic test. In other words, does it worth the costs? So, starting from the evidence of clinical benefit of calcium screening assessment, reporting the prognostic utility of the calcium score in many populations, the Eisner study published in JACC in 2009 was the first paper which attempted to answer to these questions, assessing the downstream cost of the atherosclerotic diagnostic testing, assessing all the procedures that we can use in the follow-up of the patient after the atherosclerotic imaging. So, from this result, the atherosclerosis imaging allows to better identify which middle-aged or older adults are truly at relatively high risk versus the very low risk for CVD events in the next future. Calcium imaging minimizes the resource use among the large cohort of subjects for those with a very low risk score. The majority of high-end resource consumption was really limited to the much smaller cohort of subjects classified at higher risk for calcium score. And the previous concept that calcium screening could lead to the frequent invasive coronary angiography in a symptomatic subject was not realized. And finally, the calcium score may have an important role in fostering more efficient, selective testing patterns in a symptomatic subject at risk for disease. But again, you should speak about asymptomatic subject, which is the predictive value of CCTA in subject without chest pain, and which is the incremental risk stratification benefit offered by CCTA versus the association of calcium score and clinical risk score. answer to this question came from the CONFIRM registry. You know that this is an international multi-center observational registry from 6 countries and 12 centers. In particular, the registry assessed more than 7,000 patients without chest pain or known CAD and undergone to 64 MDCT and calcium score. And so the calcium score and CCTA are able to independently and proportionally perform a stratification in risk for cardiovascular events, and they are able to add the risk predictive advantage by CCTA by, the advantage of CCTA in comparison with the simple calcium score is imperceptible compared with the association of clinical risk score and calcium score. So suggesting that the calcium score alone could be useful, could be sufficient for risk stratification in subjects without chest pain. But anyway, we need for future studies to assess the role of non-calcified plaque that we can miss, of course, by calcium score for the right risk stratification in a symptomatic subject. So this paper, published in Heart 2013, assessed more than 2,000 asymptomatic subjects classified at low risk for coronary artery disease. And from this paper that assessed the prevalence and characteristics of disease in a symptomatic subject showed that the prevalence of disease and significant stenosis are not negligible, in particular in young population. And the NCP guidelines showed a limited predictive value for the development of cardiovascular events in a symptomatic subject classified at low risk, in particular the young people. However, considering a very low event rate in this population, CCTA should not be performed in very low risk asymptomatic subject, but take into account that CCTA may have the potential role for identification of high risk subgroup in this selected subject regarded as minimal risk group by the clinical risk score assessment. So, considering the 10 criteria proposed for a screening test, in particular among these 10 criteria, 2 are relative to the disease, 5 for the diagnostic test, and 3 are typical for the treatment. Cardiac CT satisfies all but 2 criteria. In particular, the problem could be present with the detection of little pseudo-disease, in other terms, the overdiagnosis, and the affordable available of the test. And the main problem for for coronary artery disease screening by CT are related to the so-called lead tie-in bias. We are able to perform just an early diagnosis without any incremental in survival of the subject, and this is a result when the test is able just to increase the perceived survival time without affecting the course of the disease itself. Other problem could be relative to the overdiagnosis. We are able to perform a diagnosis of disease that never would have caused mortality or morbidity. And finally, there is a problem relative to the management of the incidental findings for the downstream cost test. And finally, we have already seen that this is not really a problem, the radiation exposure and the risk associated with the contrast material injection. So, move to the conclusion, I would like to mention Dr. Braunwald, one of the fathers of the clinical cardiology. He said that the prevention of the heart attacks must be the primary goal, while the treatment should be always regarded as a locking barn door after the horse is stolen. So, how best to deploy the atherosclerosis imaging, the more intensive lifestyle changes, and the early initiation of a clinical medical therapy is quickly approaching as a very trillion-dollar question. So, to answer to this question, yes or no, I would like to quote George Bernard Shaw, who said that new opinion often appear first as jokes and fancies, then they appear as a blasphemy and treason, then a question open to discussion, and finally as established truth. Anyway, the sooner we find the answer, it will be the better, of course. This is an ancient Chinese proverb who said that the superior doctor is able to prevent the disease. So relative to the imaging of clinical atherosclerosis, it matters, and we should in selected subjects because there is published evidence supporting the incremental value of non-invasive imaging guided risk assessment above and behind that of the clinical risk factor assessment, especially among the intermediate and possibly low-risk cohorts. The imaging-based bidirectional reclassification of the patients into different strata of the risk has a tangible clinical value and implication for better matching the intensity of prevention to the expected risk. And finally, New evidence is already accumulating, showing that the imaging really of subclinical atherosclerosis may improve adherence to and compliance with risk-modifying intervention. So, many thanks for your kind attention.